Again, I'd like to say good morning to patients, caregivers, families, friends, and healthcare professionals. My name is Jocelyn Lucas, and I'm a board-certified oncology nutrition specialist with the Robert H. Lurie Comprehensive Cancer Center of the Lurie Cancer Center. While we wish we were all meeting in person, we're excited that we can still connect in this virtual format. We look forward to introducing tools, techniques, and tips that you can use to re-energize during treatment and throughout survivorship. I'm pleased to announce our first speaker, Dr. Melanie Smith. Dr. Smith is a palliative care physician at Northwestern Medicine, mostly working in the outpatient setting. She has a special interest in the AYA, or adolescent and young adult cancer population. She will be talking about palliative care in oncology. Thank you for joining us this morning, Dr. Smith.
Morning. I think there was a little bit of a delay there. So again, I'm Melanie, and today I will be presenting on palliative care. So the name of my talk today is Providing Comprehensive Care, Palliative Care in Oncology. I have no relevant financial relationships to disclose. So I always like to start off when I give a talk about palliative care, both to patients, families, and even to other clinicians, to ask, what have you heard? There's a lot of misinformation and a lot of fear about the term palliative care. This is often how I feel when introducing myself to a new patient, meeting a new family, and even sometimes talking to providers. So I want to start by debunking some of what people have heard about palliative care and just really giving a good definition. So palliative care focuses on the relief of symptoms and the stress of serious illness. It is not hospice. Palliative care is appropriate at any age and any stage. Usually, especially here at the Lurie Cancer Center, it's provided alongside cancer treatment. And it is interdisciplinary. That is a key part of palliative care at any institution, and that it's not just doctors and advanced practice providers. It's nurses, social work, spiritual care. At some programs even have psychologists built into their team. So, I gave a definition, but practically speaking, what do we do? Symptom management is a big piece of our care, and we're going to go over all of these things in more detail. Another big piece, psychosocial spiritual support. So, part of the reason that we have an interdisciplinary team is because palliative care recognizes that cancer and other serious illnesses affect the patient, and they affect their whole care team, right? They affect the family, caregivers, close friends. And it's not just physical symptoms that these illnesses can cause. They cause distress, psychological distress, spiritual distress. They can cause a lot of social stresses as well. So we really try to care for the patient and family and really provide holistic care. Another big piece of our work is maximizing care at home and the advanced care planning and goals of care discussion. So practically speaking, again, where do we do it? Outpatient clinic. I think Jocelyn mentioned that I am mostly on the outpatient side. We really have a co-management model with oncology. So we are embedded in the oncology clinics, working alongside your oncologist and the rest of the team with pharmacy, nursing, nurse practitioners, PAs. We're right there with them. Often we'll see patients right with our oncology team or in the exam room before or after the visits. Sometimes it makes more sense to see patients during infusion, but often we'll just combine visits with the rest of your oncology visits. We do have a separate clinic space as well, still in the cancer center. It's in DTI though, which is part of Olson. So if a patient maybe isn't seeing oncology when they need to be seen by palliative, or they're really not following closely with oncology and they need to see us, we still have a space where we can see patients. And then telemedicine. Since COVID, this has become a bigger part of our practice. We really try and use video visits when possible. There are also some insurance rules with that You're not supposed to do initial visits by phone, but we are maximizing video visits right now, and often combining, patients who maybe need closer follow-up, but aren't here for oncology visits. Maybe we'll do follow-up by a video visit. And then the other big piece of our practice is the inpatient service, so the hospital service. So if patients in the cancer center are admitted to the hospital, our team can see them there as well, and we have a large inpatient team. And I will specify that we even have a team that is dedicated to Prentice, to the cancer patients admitted to Prentice. Oncology has always been a big piece of our practice, and we have tried to really embed ourselves with the teams taking care of cancer patients in Prentice. So I want to talk about each piece in a little bit more detail. So symptom management. This is the mainstay of our practice and often the reason that we are consulted and get involved in a patient's care. You know, as well as I do, that there are a variety of symptoms that come along with cancer and its treatment. I listed a bunch of them here, but there are more. Pain is often what palliative is known for, and often what starts a consult, just because people associate the two, and pain is a big part of our practice. And you'll hear the same pattern when I talk about other symptoms, but palliative care clinicians have extra training in symptom and pain management. So, the difference between our care and your other providers' care is that we will really try and understand why you're having pain, hearing about, hearing a detailed description of your pain, thinking about your treatment, your cancer, to try and really get a good idea of why you're having pain and what type of pain it is, and then picking the medications, tailoring those medications based on what we think will be most effective for you. That means using anti-inflammatories, like, just your run-of-the-mill ibuprofen to prescription NSAIDs, sometimes steroids, neuropathic agents. You all probably know that neuropathic pain can be really common with a lot of chemo, so we do try and treat that early. And opioids, what we're known for. I always want to emphasize that, yes, we do use opioids, and they're probably the medication we prescribe most, but we are always trying to get by with the lowest dose possible. And really, when we think about prescribing opioids, the goal is that we treat your pain so that you can function better, right? The goal is not to treat your pain until you have no pain. The goal is not to treat your pain until you're sedated from these medicines. The goal is to treat your pain to help you return to your previous level of function, or to at least as function as well as you can. We also work closely with the providers in radiation oncology and interventional pain and anesthesia. We really think about these referrals when a patient has more localized pain, that we can kind of pinpoint that something causing it, whether it's a tumor, whether it's nerve damage, something, so that we know maybe we can radiate that and that will really make them feel a lot better. Maybe radiating it isn't that important for their overall disease trajectory, but it's important for the symptoms. And for interventional pain, again, sometimes just doing a simple nerve block can make a huge difference when most of your pain is in one area. So we work closely with our colleagues here, again, working to try and get you to function as well as you can, and on the minimum medications to get you there. Other common symptoms that we treat: constipation, so common, because the medications that we use to treat pain cause constipation. All opioids cause constipation, but also I think what's less known is that so many of the medications that you get with chemo cause constipation. So Zofran is more constipating than morphine. So we do a lot of constipation work. If you talk to the nurses on our team, you'll know that they field so many phone calls about constipation, but it is a good reason to call because that can really impact quality of life. Nausea, just like I talked about with pain, is like, of course, oncology is going to help manage your nausea. We're really there if your nausea is more difficult to manage. And again, we think about like you explaining and sharing what you mean when you say nausea, trying to really identify the causes of nausea for you and tailoring the medications to treat what we think is causing that nausea. Appetite. Another common symptom, this one is more difficult to treat. So, you know, often there are some medicines that we will use for appetite. I wish they worked better, but also just thinking about, you know, ways to work around appetite to still try and get in as many calories as possible, and also to help you live and help your family live with it if you do have a decreased appetite, because that can be a hard thing and stressful for the whole family. Shortness of breath and cough, often linked. There are a lot of things that we can do for shortness of breath and cough. Also, a lot of different causes of those. So just like I mentioned with pain and nausea, trying to figure out why you're feeling shortness of breath or why you're coughing and really treating the cause. Fatigue and weakness. Two symptoms that are also difficult to treat, but again, a careful history, trying to figure out a pattern or the cause for your fatigue and weakness can help us tailor our recommendations. You know, it sounds counterintuitive, but for fatigue, sometimes a course of physical therapy can really help fatigue a lot. For weakness, I think that's more obvious. You know, sometimes you do need a little physical therapy. And sometimes these symptoms need time. Sometimes we aren't able to help those symptoms, but we are able to help you work around those symptoms. So sometimes it's making sure that you have the right support at home, that you have the right medical equipment at home to deal with your fatigue or weakness. And then another big piece of symptom management is anxiety and depression. You know, sometimes we don't think of these as symptoms because they're not physical symptoms, but you know, they impact quality of life, impact function as much as those other symptoms. Palliative care does have a little extra training in management of anxiety and depression. Most of us aren't psychiatrists, so there are some psychiatrists in palliative care, but we can work closely with psychiatry. We can work closely with the psychologists in support of oncology at the cancer center, and then also helping you identify resources closer to home. People come from all over to the cancer center, and sometimes it's really inconvenient to get referrals just in Chicago. So we will try and work with you to find appropriate resources, not just for you, but for your family. And I will say this has been one positive thing with COVID is that telemedicine is a lot more accessible for counseling and support groups than it was a year ago. And I should also mention here that our interdisciplinary team is key when we think about anxiety, depression, and coping with illness. And we will pull in, like I mentioned before, the social worker or our chaplain if we see that there are, spiritual components of depression or anxiety. So we will utilize that team to help care for you. Okay, support. I want to start by saying that, support is not one-sided. The journey with cancer is different for every patient and different for every family. So, a patient and their family members may need very different resources. And again, that is the reason why we emphasize the importance of the interdisciplinary team. Palliative care at other institutions has actually renamed themselves as the supportive care team. And I mention that just to emphasize that this is a really big part of our care. We like to think of ourselves as an extra layer of support. Again, recognizing that cancer is something that affects every part of you and can affect your family as well. So we will meet with you, and your family, or we can meet with you individually, but really trying to tailor our support to what your needs are. And maximizing care at home. I always like to talk about this because there is a perception that palliative care has access to extra resources at home that like you can only get if you're enrolled in palliative care. And that's not true. We really don't have access to any special resources. But what we do have is extra training and expertise in home care and what's available at home. And we have more time to spend with patients and families. So what we do is we really listen to you, listen to your family members, try to identify the gaps at home, what we can add that would really help you do well at home, and then working with the home health team in the cancer center to try and get you those resources. Often it's home nursing, and sometimes that means giving extra fluids at home. Sometimes that means getting physical therapy and occupational therapy at home. Sometimes it means getting the right medical equipment to you at home. And again, we don't have like special access to these resources, but we just tend to know what is feasible and practical at home. Caregivers is another piece of it. Unfortunately, caregivers are not covered by insurance. There are some patients who will qualify for caregiver services through the state. So we can help work with you to either start that process of getting them through the state or helping you and your family hire additional caregivers if that's needed. Okay, the other big thing that we do is advanced care planning. And advanced care planning is something that I still struggle to explain because it's really an amorphous and a nebulous term. But it's really making plans for your care based on your goals and values. The reason why we think this is important is because we want to ensure that your wishes and preferences are honored if you are unable to speak for yourself. When I think about advanced care planning, I don't think of one conversation, like sitting down and just talking about this once with a patient. I think about developing a relationship with the patient over time, trying to elicit your goals and values as we get to know each other, because they're complicated. So again, I think of advanced care planning as best done over time, over multiple visits. Some people think of this as what kind of treatments would you want if or when you become more ill? And that is an appropriate question to think about when you're thinking about advanced care planning, but it's also a really complicated question because you don't know what that illness is going to look like. And you might not have the medical training to know what treatments are appropriate. And again, that's why I think it's important to have these conversations over time. I also want to emphasize that I think it's important to talk about these things. This was a survey of Californians asked, if facing a life-threatening illness, would you want to talk to your doctor about your end-of-life wishes? Overwhelmingly, patients said yes. You'll see in the first pie chart, 47% said definitely, 32% said probably, 16% said maybe. Very few people said, some version of no. Yet very few had talked to their doctors about their wishes for end-of-life care. But overwhelmingly. So there is this mismatch, this disconnect of people wanting to talk about these things and doctors really not going there. I want to share at least one reason for this disconnect, is that I think it is really easy to say I want to talk about these things when I'm well, when it is more hypothetical, and it is a lot harder to talk about these things when you're actually facing a life-threatening illness. And sometimes it may change your desire to talk about it. So I think these are important conversations to have. I also think it's important for us to ask if you want to have these conversations before forcing them. They're also really hard conversations to have. They take a lot of time. So I think those are other reasons that that explain this disconnect. I like to start these conversations, so I said that these are best done over multiple clinic conversations over time. I think it's important to first elicit, what are you hoping to achieve with treatment? There are so many things that you could be hoping to achieve with treatment, right? All of the ones listed here good goals of care, appropriate goals of care. It is a very specific and patient dependent, but it's important for us to hear, what are you hoping to get from treatment? Not judge you, but just understand it. And then talk about it, because we need to make sure that your treatment aligns with your goals. Just one kind of probably oversimplified example, but, I've had a patient talk about, getting to a graduation. I think it was their grandson's graduation. And that was like a really important goal of their treatment. But we hadn't talked about how, we actually need to just reschedule chemo to make sure you feel well on the day of the graduation. So, that's a very oversimplified example, but it is an example of how sometimes we can make little changes to help you achieve your goals. Goals change over time. Again, that's why it's important that we have these multiple conversations over time, because your goals change as your disease changes, as your quality of life changes. Goals can also be unrealistic, and this can be one of the hardest parts of advanced care planning, is when we hear something that we just don't think is realistic with treatment. And I think it's our obligation to at least offer you that information that we don't think we're going to get there with treatment. So again, a really difficult conversation, but an important one to have. And I also want to remind you all that this isn't something that you have to do just with your healthcare team. You can start this process on your own and with your loved ones. So there are a lot of good resources out there to start you thinking about the advanced care planning process. I listed just a few here: Prepare for Your Care, the Conversation Project. Atul Gawande's book is a great just book to kind of read about the process. But these are all things that you can do to help inform you before having these conversations with your healthcare team. So like we've talked about, advanced care planning is the process of helping patients make treatment decisions that match their goals and values in advance of a serious illness. I don't think the part about serious illness is more important to think in advance of a crisis. Advanced directives are the tools used to document patient preferences about their care. I tend to think the advanced care planning piece is much more important than the advanced directives piece. Often I don't find the tools all that helpful, with the exception of a healthcare power of attorney. This is something I recommend for all patients. It's also something I recommend for all my friends. So it's not just about cancer patients. But what is power of attorney for healthcare? This means that you designate someone to make healthcare decisions for you if you are unable to do that. This should be someone who knows your values and preferences and will make decisions honoring your wishes. So hopefully this is a person that has been present for a lot of your advanced care planning discussions, or if you haven't had those discussions yet, someone who you would want to be present for those discussions. Completing a healthcare power of attorney requires a witness. The witness can't be a doctor or a nurse, or it can't be your doctor or your nurse, but it can be almost anyone else, right? It can be a friend, it can be a social worker, it can be a chaplain. It shouldn't be someone you're closely related to, but it's a really simple form, requires minutes to complete, and can be helpful if you ever face a medical crisis. So in summary, because I know I'm running out of time, yes. Palliative care focuses on symptom management, support, and advanced care planning. Again, I want to emphasize, we are not hospice. We are appropriate at any age and any stage. Especially at the cancer center, we are offered early alongside cancer treatment, and we are really embedded with the oncology team. And I want to again emphasize the interdisciplinary nature of our care. Like, you can't be palliative unless you're interdisciplinary. Briefly, just wanted to list everyone on the outpatient palliative care team. Our nurses, Kathleen and Joan, who do so much of the work, especially work behind the scenes. Eitan and Julie are the other two docs who work in clinic. And then Edward is our chaplain, Tara and Ellen are our social workers. You'll see from this list that a lot of the people cross over. So Joan also works on the inpatient side, so she often sees patients both in clinic and in the hospital, trying to maintain that continuity. Same with our social workers and Edward. All of the docs do a little bit, or all of the outpatient docs also do some inpatient medicine, and then we have a bunch of docs that only do inpatient, and then Jessica Pallas, who is our APN, who does mostly inpatient, and she is solely on the oncology side, so seeing patients, oncology patients in practice. That is our team. And I should have pointed this out earlier, our number is listed on this slide. All right. Thank you very much. I know I ran a few minutes over, but happy to take some questions. Okay. What's the difference between weakness and fatigue? So they are linked. And that's kind of why I mentioned them together. I describe fatigue as more like a tiredness, not necessarily associated with weakness, right? You can have weakness of a leg or your legs or your arms. So they often are linked, but sometimes we see them distinctly. So sometimes you'll just see a patient who, like, you know, can walk fine, shower fine, but they just get so exhausted by any exertion, and they're really not weak on exam. They're just really tired, and sometimes that's the effects of medicine. So it is important to discriminate and really get a good history so that we can target it with treatment. Does marijuana help with any of the symptoms? So yes, we do certify a lot of patients for medical marijuana. I worry that sometimes, like, the effects and benefits of marijuana are a little overblown. I certainly don't find it to be like a magic bullet, but I find it to be a really good adjuvant medication. There are a lot of different varieties of marijuana, and what is really hard for us as the palliative care physicians is that all we can do is certify that you qualify, right? That you don't, that, you know, you can get your card and have medical marijuana, but we really have very little influence about what products you get from the dispensary. So part of it is going to be based on your dispensary and the knowledge of the pharmacist at the dispensary. We will help counsel you a little bit about like evidence-wise what we tend to see, but there's not a lot of great evidence right now. It's evolving, you know, mostly because of the federal laws, you know, still limiting research with marijuana. But yes, we use it, we recommend it, we certify patients for it. Can you receive palliative care if I am not receiving treatment through Northwestern? Yes and no. If you're in network with us, you can certainly get palliative care here. Sometimes it's often makes more sense to get palliative care where you're getting your other care, just because of that co-management model that most palliative care services use. But certainly, if you are interested in palliative care here, call us. We'll talk to you and make sure you're appropriate. I'm wondering why oncology massage has not been mentioned as part of the overall care, as it helps with 90% of the symptoms mentioned in Dr. Smith's presentation. I agree. I think massage is immensely helpful. I do recommend a lot of people to Diane, or I make a lot of referrals to Diane. She is not actually part of the palliative care team, but I feel like that was I'm glad you mentioned that, because it is something I missed, and she is really helpful, and she is back. She was not practicing for a while because of COVID restrictions, but she is back. So we are again making referrals to Diane. How do you know if a symptom is associated with something that can be cured rather than managed? For example, headaches. I mean, it really depends. I think it depends on the history, it depends on the other things going on. But I mean, we would talk to you about that and be honest with you whether we think this can be managed or cured. We have helped patients get rid of their symptoms. And we've also helped a lot of patients manage their symptoms. So I think it's really, again, patient dependent. I already have I have already appointed a primary and a secondary power of attorney, but I've typewritten my own form and synopsis. I have also written my own will with a codicil that addresses the potential for restoration of faculties. My trouble is lying with activation of my will. Can I activate the will through Northwestern Memorial Hospital? That's a tough question. So, I mean, it really won't be active unless you're in a medical crisis. I think the most important thing is that your primary and secondary power of attorneys know what is in the will. They have copies of what is in the will. And that I would also recommend bringing them to Northwestern to make sure they're uploaded and scanned into your chart. Because if you ever do face a crisis, we will look for those documents. If you aren't able to speak for yourself, we will try to identify who you've already listed as your power of attorney, any of those advanced directives that you've completed, and we will try to help counsel your power of attorney to help follow what is written in the will. So I think we can get them uploaded so that all of your providers have access to them. Really good question. I think I am out of time.
Yes. Thank you so much, Dr. Smith, for your
Thank
time
you.
today and the wonderful information. I can speak firsthand for the wonderful work that she and her team do, helping all these patients enhancing their quality of life while going through treatment. So thank you.
Thank you.